1 minute to start. My name is Chadi Alraies. I would like to introduce to you a new series sponsored by educational grant from Options Medical. The title of the series is All In Coronary Physiology. The main objective of this series is to highlight didactics as well as discussions with experts in the field in topics related to coronary physiology, revascularization, coronary intervention in general, and coronary imaging. With that, I would like to start by introducing our guest speakers. The first is Dr. Morton Kern. Dr. Kern, he positioned as a Chief of Cardiology, Veteran Administration, Long Beach Healthcare System, and he is also a staff interventional cardiologist. He's a professor of medicine, University of California, Irvine, in Division of Cardiology. In addition, he's being the clinical editor of the Cath Lab Digest. He is the author of Kern Cath Lab Catheterization Handbook that all of us in interventional cardiology have read all of it, or at least part of it, as we are getting trained into interventional cardiology. And I have, for disclosure, I have a copy signed by him. And it's a companion to the interventional cardiac cath book, 4th edition as well. Welcome, Dr. Kern. And our second speaker is Dr. Jimmy Kerrigan. He is an interventional cardiologist at St. Thomas Heart in Nashville, Tennessee. After finishing his undergraduate degree in Vanderbilt, he attended medical school at Washington University in St. Louis, where he also completed his internal medicine training. After working for a year as a hospitalist, he joined Cleveland Clinic, where he finished his cardiology training as well as interventional cardiology fellowship. And completing training in June 2019. His clinical focus is including coronary imaging, physiology, treatment of complex coronaries and CTOs, and management of pulmonary embolism and peripheral vascular disease. He is married to his wife, Deborah, and who's a stroke neurologist at Vanderbilt, and he has 2 beautiful kids at school age. Welcome, Dr. Kerrigan. Welcome, Dr.
Thank you.
Thank you very much.
For the audience, there's a Q&A box at the bottom of your screen. Please use it for your questions. This is going to be an engaging seminar. This is not a one-way directional educational activity. So any questions comes up, please put it in the box and we'll be happy to share it. That will start with Dr. Morton Kern with his presentation. So Dr. Kern, if you don't mind sharing your screen.
Okay, ready to go. Let me get my thing up here. All right, everybody. There we go. So good morning, all. I'm just going to minimize this. It's a pleasure to be here today and talk to you about some challenges we have in our new modern COVID era. The topic I'm going to address today are challenges that we have in diagnosing and treating coronary disease with an emphasis on coronary revascularization for some of our STEMI patients. So I just wanted to review for you what we're dealing with. The COVID virus is unique. It has different particles, different attachment sources. It's an activator of the angiotensin converting enzyme system. It wreaks havoc by being able to enter a variety of cells and produce predominantly inflammatory injury. And this complicates the interpretation of its presence. On the right is a diagram from Kerrigan and the Circ article reviewing coronavirus, and it presents the symptoms most commonly identified. And at the top of the list in the box is the fever, fatigue, and chills, the systemic constitutional symptoms. And also, if you look down on the list, of course, COVID pneumonia associated with the dry cough, productive cough, and dyspnea. GI symptoms are up to 14%. Myalgia is very common at 15%. What's not on this list, and what I added for you below with that star, is chest pain. And I think chest pain in the COVID patient can be a sidelight of all of these presentations and complicate our understanding, but just keep it in mind. Now, the stages of the coronavirus were also listed by Rudinsky and colleagues this last month in JACC, and they had 4 major clinical courses. So the first course is the one we're most concerned with, is the chest pain and abnormal EKG COVID positive patient. Now, if this is a STEMI, we're going to talk about it in more detail. We take our invasive approach, and there are advantages of direct PCI over fibrinolysis as one of our discussions. We use echocardiography, and we use functional testing for some of the lesser syndromes, and our flow sheet will point us in that direction. Recall that the acute coronary syndrome and myocardial injury is greatest in the first 21 days, tapers off over time, but that the sequelae of COVID injury accumulates over time into months after the event. The second major clinical scenario we have to deal with are those patients presenting with hemodynamic instability. We use echocardiography a lot to look at LV function, pericardial effusions, valvular disorders. Pulmonary embolus is on this list. Distributive shock is on this list from sepsis, so it can be a confounding presentation. Third major clinical scenario is that of new left ventricular dysfunction presenting as heart failure. Again, our imaging modalities are standard for these individuals. Myocarditis probably is the largest comorbidity in this collection, more than coronary artery disease, and we have to consider stress and inflammatory marker injury or cytokine injury, cardiomyopathy, not unlike a Takotsubo, but it's global. And then the last scenario is late, chronic subacute phase of injury. We use our standard imaging modalities. We look for myocardial scar, which is often present on MRI in the late evaluation in patients with a COVID event several months before. So we have to think of that. And in addition, we have to worry about the venous thromboembolic risk that the COVID inflammatory system sets up for us. Now, here are the myocardial injury markers. IL-6 is elevated, D-dimer is elevated, ferritin as an acute phase reactant is elevated, and LDH is also elevated. So when we're trying to look for involvement of the myocardium, these are the markers we look for. From Wuhan, Dr. Chen and colleagues published what they believe were the hypotheses for the cardiac injuries seen in the COVID-19 patients, and there are 4 of them. There was the mechanism of ACE-mediated direct damage. There was the mechanism of hypoxic myocardial injury. There was the mechanism of cardiac microvascular damage. And lastly, there was the systemic global response to the inflammatory syndrome. Each of these has a different subset of mechanisms. ACE inhibitors involved on the far left, hypoxia and lung injury in the center, cardiac microvascular damage with permeability of the endothelial layers in the myocardium. Vasospasm also may play a role. And then the systemic inflammatory response is a cytokine storm. So all of these mechanisms, either in part or combined, act to confound our care of our patient. But nonetheless, with our abilities to do our angiograms and interventions, we have to keep that in mind, that this may not always work. I think it's instructive to recall what the high sensitivity cardiac troponin curves may look like. So from the onset of a COVID infection, days from the illness, the troponin markers start to rise, and they're highest in the 13 to 19-day window. And then if the illness persists, they continue to go up. Once they continue to go up that high level, we have to suspect myocarditis is involved beyond STEMI, obviously, and that the pictures on the right show the different inflammatory responses in lung tissue, liver tissue, and of course in the myocardium. And this is rather daunting and frightening to try and figure out whether we're in the myocarditis phase of a late arriving MI or whether we're in the acute STEMI phase. But if the troponins are rising, there's a high likelihood that we may be in the myocarditis phase.
Dr. Kern, if you don't mind me stopping here for a second. So this is, as you know, this is an ongoing issue. COVID going to be here for a while.
Yes.
And during the peak phase, March and April, there was confusion about how to manage these patients in terms of weighing the risk of subjecting the staff and the patient to infection, as well as treating the myocardial infarction. So what are the signs and symptoms or triggers for you to bring this patient down to the cath lab for coronary angiogram?
So we have to decide, based on our traditional STEMI approach. So how long have the symptoms been going on? How fast are the troponins rising? What's the absolute magnitude of troponin? And what the severity of the EKG changes are? and of course the hemodynamic compromise. So we try and resist somebody who we think has a more COVID-like picture than a STEMI picture, obviously, but we can often not separate it. So they have to be, in my book, pretty sick toward the management of a coronary occlusion rather than a myocarditis. I'm going to come back to that again because it's a big question, and maybe we have some more pointers to help us take those patients from the ICU to the cath lab who have C19. So here's just to get caught up to that. The suspected pathways of the ACS patients are broken into 3 groups. This is an ACC summary publication by Rudinsky 2 weeks ago. The acute coronary syndrome STEMI patient runs in his traditional path. He gets invasive angiography. If we see obstructive disease, he gets stented. No way around it. We take precautions for every COVID patient, but in the cath lab in particular, we are fully PPE gowned. Our lab was previously draped and covered to be prepared for COVID patients, but we have had a very low number. So those precautions have come down and been replaced with covering and keeping our equipment and stuff as isolated as possible during the procedure. The other 2 approaches for the equivocal symptoms with atypical EKG and known CAD with equivocal symptoms in EKG can be managed out of the cath lab in a traditional cardiovascular evaluation fashion. But let's take a look more at the STEMI. So probably the biggest issue we're going to face is you have the patient with STEMI, and for reasons that we just discussed, we brought him down, EKG shown, LED is occluded, but we're left with additional lesions. Now, I'm going to just show a brief case. Dr. Kerrigan's going to show a case, and Chadi, we're all going to discuss this together. But the issues in front of us are, do we believe that non-culprit lesion revascularization is going to help this patient? Do we evaluate this non-culprit lesion, and how do we best evaluate it? Do we do a stress test later, a delayed response, or do we do FFR or IFR now, which is my preferred method? But this is obviously contentious. And then lastly, at what stage are we when we see these lesions? Acute, subacute? Is he appropriate for stage management of this non-culprit? Do I want to bring a COVID positive patient back for a second go round in the cath lab? I think that is an overwhelming concern and consideration. Let's just remind ourselves that complete revascularization was favored in a number of our multi-center trials. The dynamic per multi and compare complete suggested complete revascularization was beneficial for event rates. On the other hand, there's a few other studies. Smiths and company said that infarct-only treatment, again, was a little less favorable. They had a MACE, beneficial MACE-free survival with complete revascularization. FFR played a role in both of these trials. So let's keep that in mind. Here's a quick case, brief to set the stage. A young man, 56, has angina while mountain biking. It stops at rest, returns with exertion. It's coming on now even more frequently. He's admitted to the hospital with an acute coronary syndrome. He's treated with beta blockers, aspirin, heparin, and here's his EKG. And there's little doubt that this is a troublesome EKG associated in a young man with acute changes. His previous EKGs were unavailable, but I think if we just saw this from scratch, we'd be interested to manage this. The angiograms were done. He was not COVID positive, but we had him under care, precautions. His LED was patent. His circumflex has a tight lesion. You can't see it here as well as I'm going to show you in just a minute. His right coronary artery down here on the bottom had a segment of diffuse narrowing and another focal narrowing on the bottom. So he's got multi-vessel involvement, not the LED fortunately, but the circ is tight and the right has disease that could be tight. Here's the circumflex lesion. I don't think there's any doubt that this was the most severe of all the lesions he had. We don't need a pressure wire to do this, but because I like the OptiWire, its strength, its signal quality, and its handling, we do a lot of our cases that we may have to do multi-vessel evaluation with that OptiWire start to finish. Here's our resting PDPA across this circ. There is no doubt this is a critically tight lesion. When you get your resting value of 0.63, you can imagine if I'd given adenosine, it would have gone down to 0.3 or 4. So he gets treated on the OptiWire, he gets stented, he gets IVUS, he gets his work done. And we see there, we still have a little residual disease at the ostium, which I'm not worried about because his resting PDPA now is 100% normal. It's almost impossible to go from this value to any significant hyperemic value. So I'm not going to go further. We are done with this artery. Now, we're not done with the patient.
Just
Chadi?
wanna, yeah, the current one, and that speaks to the durability of the wire to measure post PCI, which is, I think there is a recent paper showing that if you resolve complete physiological flow limited lesion, you can reconnect back the wire, and then you can confirm that you treated that vessel, you up to the next one.
Yes. So I think that the post PCI FFR, IFR, DPR is not performed enough to give us the reassurance we know that we've done a good job. What if this would have been abnormal, right? It looks great, but that little osteo lesion can be hard to determine angiographically alone. So there is a role for post PCI physiology in making better outcomes. And with this wire, now I'm just going to turn my attention to the right. Same wire, different guide. I said, okay, this could be positive. I want to be ready to go. I don't want to delay. Put in a right guide, did the wire, and look at this. Resting PDPA 0.97, nearly normal. What a surprise. And then we gave contrast hyperemia, which is already in the guide, and we just inject a little more, and we only dropped to 0.87. And remember that CFR threshold to match with FFR is 0.83. So we're way above that. And our DPR, of course, would have matched or been very close to the PDPA. So I think we did a great job in terms of complete revascularization, well assessed by physiology, and we did it with one wire, efficient, fast, cost effective. So I was very pleased with this case.
And you did this with the same wire, right?
Yeah, same wire, start to finish, one wire. We had a discussion in my group in Cath Lab Digest for the editor's page. What should we do in the cath lab? And I think that the bottom line came from perspectives which are now published by the SCI Emerging Leader Group, this just a few weeks ago again. And the following principles were guiding us and maybe guide us for selecting those patients to come down to the cath lab from the ICU. All STEMI should undergo screening, evaluation, and protection, protecting themselves and protecting us. All STEMIs, we think primary PCI is better than fibrinolysis. And you may consider it in some remote areas or when resources don't permit, but only for low-risk STEMIs. The downside of lytics is that you get prolonged ICU care, use of finite resources. They may need another return to the cardiac cath lab. We know this from our days of lytics in the past. All of our bedside procedures for those COVID positives should be done at, the procedures that we need to do should be done at bedside when possible. If you have to put in a balloon pump or do pericardiocentesis, do it in your environment that's safe. Cardiac cath labs should create COVID carts with their supplies because once they've been contaminated, there's a period of time after which you can't use them. And then you can start up again. We're doing that now. And then we talked about culprit vessel PCI, that's easy, but non-culprit lesion, I think should be assessed and then treated if positive. So you only come back to the lab once. And again, not everybody agrees with me that complete revascularization should be done in every STEMI patient. I'm going to leave my discussion there and just want to remind you that I've collected your horoscope. All you out there in the audience, if you don't know what your horoscope is for this coming week, I've provided it here for you, and Chadi and Dr. Kerrigan. I just want to remind you, if you're in Aries, your horoscope says you're going to be spending time in your home this coming week. And by the way, for you Aquarians at home, your horoscope says you're going to be spending time in your home also. And I happen to be a Libra. Here's my horoscope this coming week. I'm going to be spending time in my home. So I want to say thank you for the opportunity to introduce this topic and come back to the discussion with Chadi that what is it that makes us take our patient from the ICU down to the cath lab? Yeah. I'm going to suggest just a couple of things. Unstable condition, persistent chest pain, EKG changes, rising tropes, or hemodynamic instability, and that would include arrhythmias, pressure problems, and then cardiogenic shock. If we haven't figured out that this is not coronary related shock, I think we have to go down and make sure it's not. And then when they do come down in shock, we have the opportunity to use mechanical support device of some power, right? Not just the balloon pump, obviously. Okay, I'm going to
Absolutely.
turn it back.
Dr. Kern, thank you so much for the presentation. Really delightful insight about the COVID. Just to recap on the discussion as well, and for the audience, we are putting a poll there for you based on the discussion we had. Please plug your answers. I would like to have your thoughts as well. So as you said, Dr. Kern, and there's a SKY Emerging Leader recommendation, there's ACC paper about the COVID management in the cath lab, and there is also, I want to put a plug for a registry that started by Minneapolis by Dr. Tim Henry as well as Santiago Garcia about NACME, which is a collecting all COVID positive and ST elevation myocardial infarction, just to understand the mechanism, what we're doing. I really like the fact that you mentioned we should do more PCI and less thrombolytics, because from my personal experience, we had it done once in the CCU, and it was a disaster. The bleeding everywhere, every line was oozing. It was a big mess. And unfortunately, the patient passed away from severe lung injury and COVID. But I think we made it even worse by giving lytics. So patient selection is very important. One comment in terms of anterior wall versus lateral wall, how urgent you can bring the patient down, because there's some argument that if there's not anterior wall, not shock, no active chest pain, no VT, then you can wait on that patient.
So I think that may be true, but for STEMI patients, I don't think we should treat them that differently. I mean, they need that lateral wall eventually. I think your comment on fibrinolysis was on point in terms of, we don't know that the chest pain STEMI patient doesn't also have some other vascular bed at risk, head, heart, lung. If they bleed into those beds because of endothelial leakage, the fibrinolytics are going to wreak havoc, just as they did with your patient. So I have low enthusiasm for using fibrinolytics in this acute setting. Maybe somewhere where you can't get to a cath lab and it's so critical that it would help. But again, you get the risk of the downside of bleeding, use of more resources, prolongation of stay, and eventually they may have to come back a second time as an earthquake here. So.
Absolutely. And for the complete revasc, as you mentioned, I mean, if you have the opportunity to do everything in one setup to prevent the patient coming back and forth to the lab, exposing the staff and transitioning the patient in the elevator and exposing other even people in the hallway, I think that will be ideal in this situation. As you said, it's a controversial topic, but I think in COVID situation, maybe it's more towards complete revasc and evaluate all coronary possible with reliable wire before you get the patient off the table back to the CCU or ICU.
Yeah. So Jimmy, you're in the trenches with the practicing clinicians out there who have deal with STEMI. So it used to be that if I had a STEMI at 2 a.m., I would defer the non-culprit till another time. But now with COVID at 2 a.m., I think I want to get everything done and get rid of this guy so he doesn't come back. What's your thought?
No, I absolutely agree, and my staff are not completely on board with that at times at 2 o'clock in the morning. But I look at it two different ways. I have a patient in front of me who has an acute MI, has non-culprit lesions that need to be assessed. We'll go over the poll results. I won't bias anyone with how I do that. But for somebody who doesn't have COVID, why expose them to another hospitalization, another trip to the cath lab, whether you do it the same setting or in a delayed setting for somebody who has radiation exposure or chronic kidney disease. So get it all fixed for things that are significant physiologically and geographically. I think there was an interesting sub-study from Complete with 60% cutoff for less or greater than for outcomes. I don't tend to use angiograms. I use physiology because I believe in it. But in that setting, I think it's worth it to do it. Same thing for the COVID patient. You don't want to bring them back, expose staff a second time, get everything fixed in that setting, or potentially, and we haven't done this, let them wait several weeks, let the COVID go away so that they're no longer infectious, and bring them back as an outpatient so that they're not in the cath lab for extra period of time, again, exposing people. So that's a debate. I think for the non-COVID patient who comes in with a STEMI, that we should fix everything in the same setting unless it's harmful to do so. But for the COVID patient, I don't know what the right answer is. Do it all and expose myself and my staff for longer, or wait 2 weeks until they recover from their viral syndrome and then bring them back as an outpatient?
Good point. So just two comments. One, your 60% narrowing is my 40% narrowing. So, or it could be my 80%, depending. So just, we should remind everybody
How
that.
much do you want to do that lesion?
Yeah, it depends if you want to do it. And the second thing is the exposure risk is a high concern. Do you want to expose them twice? Because you're going to be in there twice more than 15 minutes. So obviously you should put your max protection on. Aerosolizing activities should be avoided at all costs if possible. So the COVID, when we dressed up for the COVID patient, they had a mask and a hood and a plastic drape. We had everything. And believe me, it is totally uncomfortable. I don't want to have to do that twice. So get it out of the way.
Yeah.
Chadi, what about I'm sorry. What about the poll results?
There you go. That's a poll result. I'm sharing it. Can you see it there, Dr. Kern and Kerrigan?
Yes.
So it looks like either they got well educated by Dr. Kern by doing the first question. With COVID-19, when assessing other visuals in STEMI patient, would you more likely to use an FFR, 58%, or resting indices or angiography? So majority said FFR. And I think this is more a practice, but I think it's also coming from you, Dr. Kern, with the evidence we have and the reliability of the equipment we use. Maybe it's something we should acquire now more, and people who are not doing it. And FFR will help you answer that. So our peace of mind, you can sleep better at night when you take this patient off the table, not to deal with any other lesion down the line.
Yes. So Jimmy and I were talking earlier about how much confidence do you have in the FFR value in the non-culprit, right?
Yes.
And we talked about two things. We said, one, that if the FFR or if the IFR, if either one is positive, it's true positive. You don't get false positive values. The problem comes in the negative. So if you're close to the infarct zone, like a diagonal for an LAD or a marginal for an LAD or circ, if you're close next to the infarct zone, then you may not have as high confidence in a negative number because next week it'll be positive. But if your LAD is your target and your right is your non-culprit, I think your confidence can be high because you're far away from the injury zone. So I would trust the FFR or IFR in that region or DPR, and I would question it maybe a little closer, but I probably use it because the data says if whatever you measure today generally is good for 3 months. There are some few cases that could change across the border zone by a few small units. So anyway, that's how I approach it.
If you say that the culprit is LAD and it's an OM non-culprit, is still this going to be affected, or is circ that's going to be affected?
So we won't know until we know how big the infarct zone is. We may never know. But again, positive, I trust it. If it's negative and it's far away from the infarct, I would say my confidence is much higher. And then I can use that. And if if it's negative and you leave it, you can always reassess it in the future. It's a misdemeanor, not a felony. So.
All right. And I would like to remind the attendants as well, if you have any question, please use the Q&A box to drop any questions to Dr. Kern and Dr. Kerrigan related to the topic. All right. Thank you so much, Dr. Kern. Great discussion, great case. Dr. Kerrigan, you want to pull up your slides and share your screen?
Certainly.
We're doing perfect on time.
All right. Is that visible?
Perfect.
Perfect. All right. So first off, Dr. Alraies and Dr. Kern, thank you for inviting me to participate in this discussion of physiology, which is ever more important. So I was asked to bring in some cases, a case, and then I've got a second one if time allows to look at complete revascularization with a modern pressure wire, how we are able to do that for people. Feel free to reach out via any of the methods below with questions or comments afterwards or through the chat box now. So a patient that's probably pretty common to most of us, this is someone who is in her lower 60s. She has a few comorbidities. I'm not going to read them out to you, but a patient who has vascular disease. Most importantly, she has mild vascular dementia, unfortunately, at the age of 62, and had a history of coronary disease, had stenting of her right coronary previously, came into our institution with exertional angina, nothing at rest, so we gave her the appropriate workup, as Dr. Kern explained, with heparin and medical therapies initially. She was on 3 antianginals as an outpatient and had failed that. Echo showed that her EF was normal. She had diastolic dysfunction, no significant valvular abnormalities. She had a low-risk nuclear stress test, which is of interest, but you'll see why that was. But she had ongoing chest pain. Given her prior stenting, we didn't think that coronary CT angiography would be sensitive for her because hard to see inside the stents. So we went ahead with a heart catheterization. And as you'll see, she, on injection of the left circumflex artery, see if the laser pointer works there. So she has a stenosis after the first obtuse marginal there in the mid circumflex. She's got a pinch in a relatively small third obtuse marginal. The distal circumflex has a stenosis compromising flow into the lateral branches in the fourth OM. So all squarely moderate. I think the diagnostic angiographer called them all 70s to not help any of us out. And then on the shots for the LAD and diagonal, this is with the wire down. It's the angiogram I could find that best demonstrated this. So you can obviously tell what I'm going to do. The proximal diagonal has a stenosis. The LAD itself has a stenosis of questionable significance. And then as you can see, there's filling via collaterals into the distal right coronary artery. She's unfortunately occluded all of her stents, a relatively long segment. So in the spirit of the heart team, we stopped. We had a conversation with the patient, with her family, and with cardiac surgery. This is directly from the note of the cardiac surgeon who assessed her to be high risk for surgery because of her known vascular dementia. She also had intracranial atherosclerosis. They were concerned about worsening that, causing strokes. So they said she needs either PCI or medical management. For a patient who's already on 3 antianginals with good blood pressure and heart rate control, I'm not entirely sure what additional medical management was available for her. We don't have trimetazidine in the United States. So the decision was made to provide physiology-guided PCI, figure out what needed to be fixed and provide her hopeful symptomatic relief. Again, angiograms in the ariocaudal and then in the PA caudal show the stenoses in the circumflex, and I tested all of these. So I put the optowire distal to the first blockage where DPR, was surprisingly non-significant. It only was 0.98, so indicating a non-hemodynamically significant lesion. So I advanced it into the fourth obtuse marginal where there was a significant drop. So the third obtuse marginal had a DPR of 0.86, again 0.89 or lower being the cutoff, 0.85 in the fourth OM, and with only a 0.2 drop in the mid circumflex, I thought that both of these were truly significant. Dr. Kern has taught us that the delta in this situation, at least for FFR, is potentially more important than the absolute number. So got to work. So balloon angioplasty, intravascular ultrasound for stent sizing, ended up putting in a stent and post-dilating it using intravascular ultrasound guidance. I truly believe that imaging does make a difference even in small vessels.
Was there any calcium on imaging?
It was mild. I didn't think that atherectomy was going to be needed. That being said, there was an area of focal underexpansion which finally gave to a 2.5 short NC balloon with dilation, but it wasn't more than 180 degrees in circumference. So I didn't think that atherectomy, also atherectomy in a distal circ in a 225 vessel is difficult. Maybe with intravascular lithotripsy, we'll have some more options if that all pans out from disrupt.
So IVUS shows 225 vessel size.
Correct. And then 2.5 proximally.
Awesome.
So that procedure used a 2.0 balloon to make space. It was a 2.0 vessel distally, 2.25 deployed gently, so I didn't tear the distal vessel post-dilated. And then using the OptoWire, I had the ability to plug it back in, check a DPR. I was no longer ischemic, even with that disease proximally. So I thought that got a good angiographic result, a good intravascular ultrasound result, a good physiologic result. So turned my attention to the third obtuse marginal, wired it with the same wire, where again, physiology showed that there was an issue. I initially tried to pass a cutting balloon and a scoring balloon, neither would cross. I made some space with a regular 2.0 balloon, performed intravascular ultrasound. The vessel was only 175, so I decided not to stent it. Was able to get a cutting balloon down, expand the vessel, and then the post DPR on this one was 0.94. So again, provided hopefully some relief of ischemia in that territory. Although it's small, my staff thinks I'm the champion of the small vessel for whatever reason, but I think that it helped her there. So pulled the wire back into the left main. There was no drift on pullback, and then used the same wire to assess the left system. So there's the post-intervention angiogram.
And just to comment, Jimmy, your wire gave you enough rail to advance all this equipment very distant to that circ. I feel like without kicking the guide back, and it was a reliable wire to work on.
It is. I think that that's a common indictment of some of the pressure wires that have been available, is that you can get the information, but then you need to buy a workhorse wire in order to actually provide the intervention, which then prevents us from doing post-physiology, because if my wire is out, I have a workhorse down, am I really going to hook everything back up, re-zero, re-normalize, advance it? But if the wire is already down and I'm working over it, which this wire allows me to do, there's no harm in plugging it back in and checking my work to make sure. I mean, we know now that over 30% of people still have ischemia when you test post-physiology. You know, what if in the ischemia trial, what if these patients had all been treated and their ischemia was gone, and would we have seen a benefit to patients potentially with PCI? So just making sure that we're doing a good job, and especially in the COVID era, I don't want her to come back. Ideally, especially with all of her risk factors, her contact with healthcare should be minimized as much as humanly possible. So same OptiWire, so did DPR down the LAD, which was 0.85, and then the first diagonal, which was the worst of everything, surprisingly. It is a long diagonal, but it was 0.66. So the plan was for bifurcation stenting of that vessel. So what I was able to do was put the OptiWire down the diagonal, perform balloon angioplasty with the 2.0 balloon in the diagonal, perform intravascular ultrasound, which showed me that it was a 225 distal reference, 2.5 proximally, allowed me to plan my procedure. So I put a workhorse wire down the first diagonal, flipped the OptiWire down into the LAD, and then proceeded with the rest of the case with that as the setup. So then balloon dilated intravascular ultrasound, OptiWire is now down the LAD, my workhorse is in the diagonal, and then beyond that, it's a typical DK crush. I didn't save my kissing balloons, but throughout. So a single stent in the diagonal, single longer stent in the LAD. It was a 3.5 distal reference, a 4.0 proximal reference, so post-dilated per the music criteria to 100% of the distal reference throughout the lumen, and checked my work both with physiology and with intravascular imaging, proximal optimization, and then a completion angiogram. And I took some planning shots for her RCA CTO. You can see some backfilling into the distal right, just in case she didn't feel better, to figure out what we would need to do. But you can see here that the circumflex, the LAD, the diagonal look adequately expanded. And on physiology, I was able to, again, use the same wire, plug it back in the LAD, clear the contrast. The DPR in the LAD was 0.92, so again, greater than 0.89. And then the diagonal was actually 0.96 after I pulled the workhorse wire. So the worst lesion to the best from a physiologic standpoint. So completed her procedure, all from the right radial approach. She went home the next day, did well for quite some time, was being seen in the office by one of my partners, and then had angina again. So came back in for diagnostic angiograms, and her left-sided system was patent. MRI showed that her right coronary was viable. So decided to go ahead. And this is temporally removed by about 6 months, but here you can see that the stents on the left side are all still widely patent. There's no issue there with any of the work that we had done earlier. Ended up fixing, always good, the angiographic Levine sign when the patient tells you it hurts right here on the fluoro. Ended up lasering, ballooning, extending the stent ever so slightly, unfortunately, because of some distal missed stenosis. And she's done now for several months after that, done well. She actually is now exercising to the point that she complains that her legs hurt with her PAD and not her chest anymore, which is, I think, a decent sign. So that is, a patient that we provided legitimately complete revascularization. I didn't use the OptiWire for the CTO. Would be interesting to try that at some point, but who has done relatively well.
Thanks so much, Jimmy. Can you go back to the last shot, the final shot of the left system as giving collateral to the right? And I would like to ask you, how come a donor vessel IFR be affected by physiology? Would that change the numbers? If you fix a CTO, would your references would be different? And what's your practice?
Sure. So I can answer the second question first. My practice is to believe the data that's there in front of me and try to do lower risk procedures for the patient before I expose them to a risk of CTO PCI. I enjoy CTO, and don't get me wrong, I want to do it. But I think that, and we know that resting indices, hyperemic indices, it all depends on what is downstream of the vessel. So if you have, in this situation, the LAD is feeding the distal right coronary, you've expanded the distal bed. So in this situation, if you were to go back and do the CTO, I think data would suggest that potentially if you repeated a physiologic assessment of the donor vessel, that there would be a change. Usually it's not as severe because you've now taken away that distal bed. It's a smaller territory. That being said, I still use it. If something is very borderline, then there's a consideration. If I have a DPR of 0.88 or an FFR of 0.79, then you don't feel quite as good as, if you have a FAME1 level FFR of 0.72, then you know that you're still got a significant lesion there. But to answer your question, I use the physiology to guide my intervention. I treat to an adequate outcome based on what is there, and then I defer CTOs as long as possible, but have no qualms about doing that in that setting.
Dr. Kern, any comments on donor vessel FFR?
Type 1 error, Dr. Kern.
Can you unmute yourself?
Okay, so I committed a type 1 error. Type 2 error is where it's not muted and I start talking. Okay, so the donor vessel flow to an occluded bed is larger than it would be after you open up that chronic total occlusion. Okay, so the change is really more affected by on the hyperemic side, and it is affected probably a little bit by the resting flow, but the proponents of resting indices would say there's not much change. I don't think I've seen the data on that particular experiment, but I believe that the change, even though you do open it up, the change is modest, as Jimmy just told us, probably a few units, 0.03 to 0.04 around that threshold. So if you're already positive, markedly positive, it may change a little bit toward negative, but not much. If you're right at the threshold, it might cross it, but again, you have to decide how confident you are in fixing, in relieving the clinical scenario by changing it. So treating an FFR of 0.82 that used to be 0.79 after you open the CTO is probably worthwhile. Again, I think the cases are not so common, but they are important. There were a couple other points that I wanted to make beside the physiology of the donor vessel. That situation is worth talking about for a long time, but Jimmy, we, in our lab, we don't treat vessels smaller than 2.225. 225. 2.0 is out, 1.75 is way out. And so the benefit, and the reason we don't, because I come from an era when small vessel angioplasty didn't maintain a patent vessel. And even if we had created a stent-like result with an FFR of 0.90 or greater, often, the smallest vessels would come back, either close or restenose. We used to be able to use, or maybe we still can, if your final balloon angioplasty result in a vessel is 0.90 or greater, then you had a similar outcome as if you had put in a bare metal stent. Now, that's not great, but at that time it was great. This is in the 90s, early 90s. So today with drug-eluting stents, we really have to understand that a balloon is not as good as a drug-eluting stent, no matter what final FFR you get. But the higher the FFR after stenting, the better the outcome. So we do know that. And also that the post-PCI FFR tells us not only about the lesion and the stent, it tells us about a hidden lesion, a more proximal disease, more diffuse disease, and a pullback really shares its knowledge about being diffuse. Can we treat diffuse disease? Not very well. Can we treat hidden focal disease? Yes. Should we? Yes, because as you said, a third of our patients are still ischemic after stenting a culprit lesion. This is not in the STEMI patient, but in the regular PCI. So I think that your case was wonderful. I'm not sure I would be working in such small vessels, but that's just me.
Fair enough. I told you I'm the champion of the small vessel, according to the staff. Chased every RV marginal and OM.
Yes.
but you know, I just wanted to make sure that she didn't have to come back. I didn't know that it was a 175 vessel until I IVUSed it and felt a little aggressive 208. But you know, I'd already committed to that point. I think the other value too, what was interesting, I was looking at a case report at some point, maybe it was on Twitter, of post-PCI resting index that was still abnormal, and there was a great angiographic result. On OCT, there was a thrombus that they had not appreciated angiographically. So I think complication management for identification of edge dissections that are hemodynamically significant, or thrombus in this case, in addition to underexpansion and malapposition, there's a role for post-PCI physiologic assessment to help make sure we don't leave them with a bad result.
Yeah, so you have a free, if you're using an OptoWire and you're doing your case on it and you finish your case, you plug it back in, you get a free look. It's not a complicated thing. It's just more information, better information. So I think we really underestimate the value of this post-PCI. That case with a good angiogram and a thrombus, that is a perfect example. Rare, but a good, all you need is one. You'll be a believer.
Yeah, I think that there are ongoing trials that will hopefully shed some light on the issue, and maybe we can design something to answer the question of the CTO resting index. Put a pressure wire in to stabilize, measure pre and post, and maybe defer some interventions.
I'm sure somebody's already on it, but yes. And the fact that we have that wire to use is really an advance in the field.
Certainly.
I think we still have time for the last case, Jimmy. Yeah. But as he's getting ready to share his slides, and also there's a poll going on, please make sure you pull your answer there. Dr. Kern, comments on resting indices in shock patient, how reliable they are.
Holy cow, I have no idea. But all bets are off in the shock patient, honestly. So if you're in shock and your pressure's in the 80s and you're using a pressure wire to assess a lesion, you're going to have some trouble. So I don't know what to tell you about that. The shock guy, I do know this. If your LVEDP is very, very high, there is some question whether you're getting an optimal FFR result. Right. Nobody's tested it with IFR. If your blood pressure is very low, you're going to have a more impact of the right atrial filling pressure on the calculation of FFR. And we did a little study about right atrial pressure increases, how they impact FFR calculation. So as you increase your right atrial pressure from 5, 10, 15, and 20, it only impacts your FFR calculation when your blood pressure falls from 100 to 90 to 80. Not until you cross 80 or even 70 do you get a relationship between the RA pressure producing greater than a 0.05 unit change in your calculation. So the shock patient, he's got both. He's got hypotension, he's got high RA pressure, high LVD pressure. Physiology may not have a role in this guy. You need to stabilize him first, revascularize as best you can. You know, if you make a mistake and revascularize something that didn't need it, it's not criminal. Again, we talked about felony and misdemeanors. You know, you can always, he'll tolerate one more stent if he survives the hospitalization. So I wouldn't get too wrapped up in the shock lesion assessment business. I know somebody's gonna, I can't wait to see it, and good luck to you, because I want to be there when you publish it.
Right, great. Just pulled up the result there for you to watch. With COVID-19, are you more likely to provide complete revascular STEMI patients? Majority is 62% yes, they would like to do that, to being consistent with what we're talking about. Jimmy, go ahead with your second case. Thank you.
Sure, of course. I'm going to make sure I'm not committing a type 1 error. All right, so the second case is a gentleman who's actually, you know, over the age of 90, but for HIPAA purposes, 80 plus, who has a history of hypertension, has a GFR of 32, bled a month ago, unfortunately, came in through a vascular surgeon with lower extremity claudication. And the surgeon, given his age, wanted cardiac evaluation. So he was referred to another cardiologist at another facility. Stress test was obtained, which showed ischemia inferior and anterior anterolateral with a depressed ejection fraction. So a relatively high-risk stress test. And the outside facility performed left heart catheterization. I wasn't able to save the cine angiograms because it was outside, but this is his left system from a cranial approach. Laser pointer, distal left main has a little bit of a bite taken out of it. The LAD itself is chronically occluded. And then in the caudal approach, there is a large ramus, which has moderate disease, and then the ostium of the circumflex looks significant, 80+%. Again, to Dr. Kern's point, how aggressively do I want to treat that? Is it a 60 or an 80? But in any case, it looks like it should be something real. And then in the right coronary, from a LAO-cranial, you've got a significant stenosis in the mid-segment with moderate disease otherwise. So after obtaining this angiogram, this guy who did not complain of any angina was admitted to our hospital, transferred via ambulance for consideration of emergent bypass, which, you know, given his age and comorbidities, was unlikely to be done, but we went through the process with the heart team approach. When he came in, he also said, well, yeah, I've been getting short of breath, but my legs hurt so much I don't really do it, and he's had decreased energy. He had gone to exercise therapy for his claudication, but he couldn't breathe to participate in exercise therapy. So, you know, no frank angina, but some anginal equivalents potentially. And given his stress test, we thought that these were going to be real. He was seen by surgery who thought that surgery was not in his best interest. So the vascular surgeons asked us to figure out what we could do. They thought that he could stay on a P2Y12 inhibitor, that he would be able to be treated in a fashion from the leg standpoint that would be appropriate for that. Excuse me, but they wanted anything that was significant or severe to be fixed prior to them working on that. So back to this angiogram, I think that none of us would say that the mid-right coronary lesion was not severe. So the plan was for PCI of that in order to relieve that area of ischemia. And then with the equipoise in our mind, we don't know, is the ischemia in the anterior wall because of his LAD CTO, or is it because of his circumflex or his ramus or something else? So the plan was to assess those physiologically in order to figure out what needed to be fixed and what could be safely deferred. And we know that CTOs don't have to be fixed prior to surgical evaluation. So straightforward post PCI result on the right coronary artery, single stent, 4.0 dilated to a 5.0 with intravascular ultrasound guidance. You know, honestly, we used a workhorse wire for this. We didn't check pre and post. It would have been very nice to do so. Didn't think about it at the time, but then used the Opta wire for the left system in order to assess the lesions. So, you know, down the circumflex, this was a bare to wire. It was a retroflex circumflex with a tight osteal lesion. So, you know, good FFR hygiene, no contrast in the guide, give nitroglycerin after you get the wire down to rule out wire spasm, normalizing the aorta or the left main. And here we gave, after we got the value, which was surprisingly normal, 0.97 if I recall for DPR, gave a little puff of contrast to make sure that we were actually in the right vessel, because we couldn't believe the numbers that we had gotten. But it was accurate. So cleared the guide again, pulled the wire back into the left main, advanced it into the ramus, where we also were able to obtain a DPR that was non-ischemic. So able to defer intervention for the ramus and the circumflex and say, well, if you continue, if you have symptoms, once your leg is fixed, we can talk about your LAD.
Jimmy, this video is very good illustration of torqueability of the wire and how it's navigating that tortuosity. Thanks for showing it.
Yeah, it was some aggressive wiring. This is actually one of my partners who was getting his hands on the Opta wire for the first case. I don't know if he's watching or not, but definitely one-to-one torque. Could work over it, as I demonstrated in the last case. Thankfully, this patient didn't need anything on their left system. And then just a little puff of contrast to make sure we hadn't heard anything.
Nice.
So total 10 cc's of contrast given for the PCI on 26 minutes of fluoroscopy. So again, the ramus DPR was 0.91. The circumflex, the worst of the lesions outside of the right, was 0.97. Went home after getting hydrated overnight, came back a month later. His GFR was better, although that probably correlates to a change in creatinine of 0.01 given his age. His legs were hurting, but he was breathing better. So I think that we truly were able to give him symptomatic relief, give him as little stent as possible, knowing that he was going to be going through a vascular procedure, which ended up being endovascular. It wasn't a big deal, but didn't want to have a lot of metal in there in case they needed to do something open and, you know, bridge him with eptifibatide or something else. But overall, I thought it was an interesting use of the wire, and that circumflex, again, was just a lot of fun. We were talking about getting a supercross catheter, an angled microcatheter, to actually get it in there, but eventually we were able to just wire it with that wire.
Great illustration.
Great case. So,
great.
Oh, go ahead, Chadi.
Yeah, we have the last poll on the screen. Please go ahead and pull it. Go ahead, Dr. Kern.
Well, I was saying, I just wanted to comment. You know, these seniors are the most challenging group. And an asymptomatic guy with multivessel disease, he needs his leg fixed. The surgeons say, oh, fix his coronaries. And they don't appreciate the fact that it's not so easy to do all the time. The question is, do they really need us to fix the coronaries? And, you know, if his leg problem is greater than his chest problem, then his legs go. And I think we'll have to manage him at high risk.
Absolutely.
Otherwise. Now, the question will come back to us, did we reduce his risk by revascularizing him? Because the data is somewhat shaky on that, you know, we do revascularize many times, but only because there's fear without support that this is the right thing to do. So I think you did a good job. And that's our traditional approach to patients who have coronary disease undergoing major vascular surgery, is to revascularize when abnormal. But he's asymptomatic, and I know the dyspnea is there, but there's a lot of cause of dyspnea in a 90-plus-year-old. So, good job.
Question, yeah, great, congrats, great result. We have a question from our audience. Please explain resting and hyperemic differences and pullback results, especially in tandem lesions.
Jimmy, did you want to take it? I can do it, but
You wrote the book on this. I am not going to over you on this topic, of course.
okay. I'll give you the short version on the pullback. So the short version on the pullback is this. I think the resting indices make it easy, truly. You put your wire distal, you see your units of pressure, you pull back, and if you have co-registration, that's best. You identify your location of pressure change in the resting indices. And so you have your units changed. Now you can do it also with hyperemia. So you were going to do an FFR. You put your wire distally, you turn on the hyperemia adenosine, you pull back and you see where the delta pressure is again, and you look at the largest pressure gradient. And then unfortunately, if you have to treat that and then reassess the proximal. Whereas in the resting ratio, you can see them individually, the theory being less interaction between lesions to produce false results. So in the tandem lesion in FFR, you know, there is some reduction in hyperemia, one lesion due to the other or impacts the other, and so we don't do that. I would say right now I'm kind of leaning toward resting delta P, and it looks pretty good. I'm not sure that the topic is complex, but Jimmy's approach to getting a DPR, pulling it back, checking proximal, putting in another branch, I think is the way to go. In your case, Jimmy, left main looked like it could be positive. Certainly the osteal circ, in my view, is scary, but I've encountered negative FFRs and DPRs and PDPAs and such lesions. And then your assessment of those other branches, I mean, you've done everything you can do. And with one wire, impressively with one wire, because I know there are days we couldn't get a wire around that circ, another pressure wire.
Question about osteal lesions. How do you put your pressure wire distal? How do you evaluate resting pressures? That's coming from me, by the way.
Okay. Why don't you take it, Jeremy, and then I'll chime in.
Sure. So I think that we've seen that, especially for resting indices, that osteal LADs are difficult to sometimes assess. So in that situation, I don't think that there's any harm in buying adenosine, doing the contrast FFR, confirming your data. If you truly see that now in that nonagenarian, which is also my specialty in addition to small vessels, I didn't really want to treat that proximal circ, but I could have potentially bought adenosine, given adenosine, see how that responds, or give 10 cc's of contrast into the left system and truly confirm whether or not that's there. But I think that there is some question about, especially a resting index in the proximal, but my strategy, my practice is to put the wire down the distal LAD. If there's an osteal stenosis, I don't just put it right after the stenosis. I want to measure the bed, get a resting index. If the DPR is normal, then unless it's completely normal, back to the idea of a gray zone that we used to use of that 0.86 to 0.93, which some wires still have, I guess, then give adenosine to see. I don't want to miss something that's going to be life-altering for this patient, especially now that we can do robotic mid-cab and give them a mortality benefit potentially in a stable syndrome.
So let me just add 2 seconds. I know our time is approaching, but there's two kinds of osteal lesions. There's aorto-osteal coronary, so left main osteal right, and then there's branch osteal coronary. So that could be circumflex off the left main, LAD off the left main, or diagonal off the LAD. So for aortoosteals, those need IV adenosine. You need to match your pressure in your guide catheter without seating. You seat, advance your pressure wire, unseat, give IV adenosine. That's the standard practice. If you're going to do hyperemia, you can do it at rest. You'll get whatever resting value you get, and you can use it. I haven't heard anything to the contrary. Again, I haven't seen formalized collection of studies, but I think it would work. And the resting would apply in both aortoosteal and branch. And you do want to be a few millimeters beyond the stenosis, so you're away from any turbulence and you permit laminar flow to produce pressure recovery. So that's why you want to be a little bit away from your lesion, although pressure recovery in those lesions occurs within a few millimeters, 2 to 3, but 10 artery diameters is the safe zone. So in a 3 millimeter vessel, sort of 3 centimeters is where you should be measuring, 2 to 3. Same thing in a 2.5.
This cell by 3 centimeters, right? That's what you're referring to.
Okay. Move the wire down the length of the black portion. That's 3 centimeters. So very handy. And again, I have really appreciated the high quality handling of a wire, like the opto wire in particular, and not because I'm biased, but the wire works. And I think all these conditions benefit by having an easy wire to measure complex lesions, complex anatomy, bifurcation, trifurcation, osteals, etc. So that's my take on the aortoosteal lesion. Good question, Chadi.
Thank you so much for Dr. Kerrigan, Dr. Kern. It was a really pleasure. I learned a lot from this webinar, and I hope all the audience who joined us today also learned as much as me as well. Found it useful for your practice. And if you have the technology, great. If you don't have it, maybe something you can think about. We showed you all the bells and whistles of the functional specifics of the device and the wire. And the struggle we have with physiology. It was a comprehensive, almost review, 1 hour of resting indices, FFR, complex coronary intervention, CTO, imaging. It covers it all. Thank you all for your time, Dr. Kerrigan, Dr. Kern. Always a pleasure again. Thanks for Charles and Chantal behind the scenes